Hey, Doc Fitz here for our little update, our weekly update. Very, very exciting stuff going on. And we're really thrilled with the feedback and the questions from all you guys. It's really, really fun for me to get those. Please keep them coming. We love it very much. I'm at Pure Life today instead of the practice, and we're going to be open shortly. We hope. Very excited to see everybody back as soon as possible. We are doing consults next door, but no treatments until the governor opens up spas, hopefully very soon in the near future. As we're opening up and things are getting very, very exciting, everybody has been interested in the testing and the serology versus the nasal swab versus the nasopharyngeal swab versus the buccal swab. Well, I am a medical technologist, but then I became a physician, so this is really fun for me and I really enjoy the questions. Some of them starting out were like, is this FDA approved or is this FDA approved test? The FDA has approved for emergency use the serology, the nasopharyngeal, the buccal, all of those swabs. They could not be performed normally unless the FDA gives approval for emergency use. And it was such a great question because it doesn't mean FDA approved like that they agree with 100% of everything for every modality, including the nose and the buccal and the saliva and the finger stick. But the science is good enough for the FDA to say that we used FDA approval for emergency authorization for these tests. Their doctors and scientists have reviewed those and approved them for emergency use. I wanted to make just a 30-second update on hydroxychloroquine because you know I've been pretty excited about hydroxychloroquine, azithromycin, and zinc combination from the French study from almost 2 months ago. He had a 99.3% success rate with those three medications early in the progression of this disease. There was a couple of studies that came out and the AP put something out that hydroxychloroquine alone didn't work in some veterans and they passed away. There's a higher risk of death. Well, that was really heartbreaking to see. So I really try to just serve you guys and serve our community. I'm not political. I don't want to be political with all this kind of silliness. But as far as safety, it was crucially important. And I took an extra year of tropical medicine. I'm certified in tropical medicine as well, which is really fun. At Michigan State, I took an extra year of that, and I went to the CDC website because we've been using hydroxychloroquine for over 30 years when people go to travel to those areas, and our kids go on mission trips and go to Africa and those places. This was a cute little slide from the CDC website, okay, that hydroxychloroquine is safe both in adults and children of all ages, including pregnant women and nursing women. So I hope that ends like some of the controversy as to whether hydroxychloroquine is safe. I don't know what's going on with the TV or some of the comments about this really incredible medication, because you can yourself go to the CDC website and look at malaria, the malaria section, and hydroxychloroquine right from the CDC website. Both adults and children should take the medication, and it's also good for children of any age, nursing mothers, and pregnant women. It's safe in all those populations. So we'll set that aside, and we'll go to the really exciting part, which is really the nasopharyngeal swab versus the buccal swab versus the serology, the blood test when they have to draw your blood with phlebotomy. And a bunch of really great questions came over on the several medias. And we did get in contact with the American Clinical Laboratory Association, which is the head of all the testing. There's kind of a lengthy statement, which I really wouldn't mind reading just so to give everybody a whole baseline. But I'm going to try to make a real quick synopsis for people that don't want to listen to me kind of read this whole like 3 pages. The serology testing, or the blood test, when we have to use a needle and go in your vein and pull the blood out and send it to the lab, that's the one that tells you the IgG, the old gold. We had that graph from the last time. Sorry to refer you to that. I should have brought that with me today too. But IgM is the acute phase of any infection with a new bug. Your serum produces proteins to fight that antigen. The antigen is the virus or anything new that comes into your body. Your body reacts and produces that IgM and that IgG to fight off the infection. The IgM in the serology, the serum, is the acute phase reactant. The IgG is the old gold, which can confer immunity. Now, they've said in all the reading and all the stuff that I've done, and also talking with the lab and the other infectious disease physicians that I know, that of course, like for every other disease up till now, like if you got the IgG for this corona, that would confer that you are immune from probably most likely getting it again. However, they say there's no 100% guarantees. Then my beautiful graph that I had with that double wave, there's a thing called a secondary antigen response. So if you get, let's say hepatitis vaccines, it's a series of 3. You get a hepatitis shot right now, hepatitis shot in a month, and another shot in 6 months. And then they've got to draw your blood to see if the shots had you convert so you're immune to hepatitis B. Now, with this virus, the IgG is what everybody's really interested in. I wish I had the IgG. I've been working November, December, January, February, March, into April. We're into May. And we did my blood test, and I don't have any IgG. And I wish I had it because that would be the old gold. I would be immune, and with my asthma and with my wife with her rheumatoid, boy, we really would have wished that we had the IgG. That means we had the virus. Our body made proteins, IgG, against the virus. So now we're protected. So what does this do? What does this do? Because I don't have the IgG from the serum, okay, I can still get infected with the virus, and with the asthma, it's pretty serious, potentially for me and the missus. Now, if I had the IgG, can I be totally safe? Well, pretty much, knowing that the second time, can you get reinfected? If I got the virus or exposed to it again with a healthy dose of that virus, then I could possibly get like a cold again, or I could get a little runny nose, but it won't be as severe. But that's the immunity that we're all looking for, which is fantastic. So the great questions are, hey, listen, well, why didn't the nasopharyngeal swab tell me, that either I have it or I don't? So the nasopharyngeal swab, when we go way up by the eyeball with that long Q-tip, the buccal swab, okay, those only tell you if the virus is present in those secretions, that you've been colonized or that virus is in those areas, which would confer that you're infected with that virus, along with the symptoms. Never, ever treat the test. Treat the patient. Never treat the test. Treat the patient. There are many things that could happen with that test. I'm a medical technologist. The laboratory is very busy. They're processing millions of swabs and blood and specimens. There could be human error, there could be lab error, there could be all kinds of other possibilities. So the most important thing is never look at one test. Never look at one single report and say, well, that's it. Obviously, if you're not feeling well, you want to see your doctor or your provider, someone you trust, and you want to check another test. There was a great show called House, and it was a kind of a cute old show, and it was probably the most realistic, where the actor was like, look, he was the physician, check it again, check it again, check it again, I don't believe it, I don't believe that result. I had a sweet lady for 5 years. I told her, I said, listen, I really think you're developing lupus. I am not. My ANA's been negative all that time. Well, sure enough, 4 years later, her ANA lit up, and she was developing lupus. The symptoms were there before the serum converted. So, just to go to some high points, synopsize, and then I'll read this statement for you guys. The number one thing, what are we doing with the testing? The nasopharyngeal swab way up near the eye, the nasal swab, the buccal swab, the Q-tips, That tells you, are you currently infected with the virus and you should shelter in place, stay at home so you don't infect anybody else. Then, like a couple weeks or 2 or 3 weeks later, if you got the blood test, if you got the test, from there, you would obviously light up with an IgG, which is the old gold. That would confer that you are now immune or potentially immune to getting the corona again. Does that guarantee you're not going to get the corona again? No, it doesn't convey that. However, you've been exposed to it. Your body's prepared for it now. An ounce of prevention is worth a pound of cure. So you can then fight it off better because you already have the antibodies to that antigen, which is the virus itself. So with that, I was going to read some of the high points from this statement from supporting a comprehensive nationwide response to COVID-19, the role of serology. So again, serology or serum, you can think of serology serum, that comes from someone taking a needle and pulling the blood out of your vein, not any kind of swab for that. So, serologic testing, methodology, and laboratory capacity. The serologic testing is used to analyze blood specimens for the presence of proteins called antibodies. The presence of antibodies indicates an individual has been infected by that specific antigen, the virus. For many infectious diseases, serology is used retrospectively to confirm prior infection or indicate that the individual has developed an immune response to that pathogen. While this immune response suggests immunity from possible reinfection, the duration of how long this could last is unknown for corona. Another cute little quick example, shingles or zoster. Shingles is chickenpox reborn. So shingles or zoster is chickenpox reborn. I got the shingles vaccine about 5 years ago. It's 70% effective. Nothing is 100%. The shingles vaccine is 70% effective, so that even though I've had chickenpox, I will not get shingles. So I went and paid for the immunization. It's only 70% effective, so I could potentially have my blood drawn and see if I have the antibody to shingles now. That's one way to look at that. The laboratory-based serology requires a blood sample venipuncture from your arm. It's usually acquired by a licensed phlebotomist, a nurse, or another healthcare professional. It is placed in an appropriate specimen container stored at room temperature and transported to the performing laboratory. The laboratory needs to have all the necessary equipment, PPE, consumables, and so on in order to perform the test. As has been the case with SARS-CoV-2, which is the corona, the molecular diagnostic test, the reference laboratory performs serologic testing based on chemistry analyzers that are commonly available in major commercial laboratories and hospital laboratories. Currently, a number of in vitro diagnostic manufacturers are working with the US FDA to bring reagent kits to market pursuant to the emergency use authorization. So again, these tests have been approved by the FDA for emergency use authorization. It was such a great question. Does that mean they're FDA approved? It doesn't mean they're FDA approved, but they're approved for emergency use authorization, meaning their scientists looked at everything and said this is the best that they have at that time to get started. Not every manufacturer's kits can be run on every single platform, but in most cases the manufacturer's reagent kits are not specific to one platform. Test methodologies. This is getting into the fun stuff. And possibly the reliability of test results differ depending on the setting in which the test is performed. A reference laboratory, which is called point of care. So a reference laboratory for the COVID-19 at the point of care is really one of the best ways to do that because there's less people coming in contact with that specimen. A cute little example I kind of gave with our beautiful daughter Colby. She was at Florida State. She had a horrible sore throat, and she had the swab, and the swab for a strep culture is supposed to make it back like at least that far. It's got to make it back that far. Well, the person performing the test, you got performance error possibly. They took the Q-tip for the nasal, for the throat culture, and they put it in her mouth, and she gagged and pushed the swab to the roof of her mouth. So they never potentially got the swab all the way back to her tonsil to get some of that on the Q-tip. So her strep culture had come back negative. Her throat was getting worse and worse and worse, so we had her come home, and instead of doing another throat culture, we drew her blood. I know, being a medical technologist and a physician, the ASO titer, instead of just the strep where they put the thing and try to grab it from your tonsil, the blood test is way better. So anti-streptolysin O and a monospot, and no wonder she wasn't getting better because she lit up for both. So the serology, when we draw the blood from your vein, is your body making proteins against that antigen, kind of similar to the strep. So with bad strep throat, you will have an anti-streptolysin O antibody in the blood, in the serum, which really shows more specifically that yes, you indeed have strep throat, because the throat culture is a false negative. Operator dependent false negative. They didn't get it back there. The same thing can happen potentially with the nasopharyngeal swab or the person doing the test. The same thing with the nasal swab, the buccal swab. The blood test, in my opinion, is much, much more accurate. So what's really, really fun is we're getting ready to open everything up and go back to work. And early, like in the discussion, I was saying the nasal swab, the nasopharyngeal swab, and all the Q-tip tests. That shows that you had an acute infection with corona. The antibody test, the antibody blood test, shows could you possibly be immune. That is the key. That's the key to the whole thing. If I wish I had the IgG when I got my blood pulled, because I could just say, hey, I've got the IgG, the old gold, the antibody. Not only did I have the virus, but I mounted an immune response to that, so I'm potentially immune. Even if I get it a second time, I'll just get a much milder course. So the antibody serum test, the blood test, so antibody blood test is what I'm kind of synonymously talking about. So because the serologic antibody blood test only assesses the presence of antibodies post-infection, it is not recommended that it should be used to diagnose the acute infection. The acute infection is not the antibody blood test. The acute infection is for the nasal swab, the nasopharyngeal swab, or the buccal. That shows the presence of the virus in those secretions. The serum blood test, antibody test, shows that your body's had that for 10, 14 days. It mounted an immune response against that virus, which means, hey, look, maybe I can donate my serum. Maybe I can help other people. Now I can go back to work safely and most likely not be infected again. Even if I do get a little infection, a secondary antigenic challenge, it won't be as bad or potentially as bad as the first infection. So it's important to note, there's no test that's perfect. There is no test that is perfect. Never treat the test, treat the patient. Never treat the test, treat the patient. A quick little 10-second review. The nasal swab, nasopharyngeal swab, buccal swab are for acute infection. Do I have acute infection with the virus or not? The antibody serum blood draw, the antibody is fantastic for I can go back to work safely. I can go back to school safely. Many businesses are going to ask for your immune status or if you can enter the building. I also work at a nursing home, and I showed them my antibody test. Even though I don't have the IgG, I'm also not infected, so I can actually go in and take care of my patients at the nursing home. So all of this, getting back to work, getting our economy roaring again, is going to be multifactorial with all of the testing that we've talked about in the previous little lectures, which are really, really fun. We do love the questions. We hope you keep them coming. If you have any issues or whatever, we're happy to see you next door at the family practice and discuss that. And if you send the questions, I'm happy to try to go through them at the end of our little updates. Were there any questions from the previous that you wanted me to address? Well, listen, we love you guys. We're here to help. I hope that cleared up some of the issues. As far as the funding, again, doctors don't get money for tests. We don't get any money. We get no money for lab draws or nasal swabs or throat swabs, or the Stark laws prohibit us from making money off of laboratory tests. So the reimbursement all depends on your individual insurance. Most insurances cover it. I think we take over 20 plans next door at the family practice, and each of them has a different laboratory benefit. Each of them has a different pharmacy benefit. Each of them has a different copay. I can't keep all of that straight for each individual patient, but most of the time, the lab is almost 100% covered, but you would want to do that research with your own insurance company to ask what your benefit is. But self-pay, even people that are just paying cash, if they have no insurance at all, and they just want to know, I believe the test is $100. It's gone down from 120 down to 100. Whatever it is, that money goes directly to the lab. We don't benefit from that lab test. It's really important that you all know that. We're really, really excited. Things are getting better, and you guys have been amazing. We really appreciate, trying to keep a good attitude. I think that's the most important thing. So thank you again for watching. Sorry this was a little long, but good luck, God bless, and thank you.